Okay, so it looks like we are ready to go to talk about Module 2. So we're going to look at first rational drug selection. This is Chapter 3. How we're going to do these slides, because I know there's a lot of them. I'm not going to read every slide to you. That kind of defeats the purpose, of this whole thing. So, I'm going to go through, give you some extra information on some of the slides, kind of skip over them. All of them can be used for your quizzes and your exams, but there's no reason for us to have a 2-hour lecture on these topics if it's just me reading the slides to you. So the process of rational drug prescribing starts with defining the patient's problem and the specific therapeutic objective. Then you collaborate with the patient, which is always important, because if the patient doesn't believe in what you're doing, they're not going to take the medication or whatever the treatment is. You choose the treatment, educate the patient, and always monitor for effectiveness. So you're going to assess the patient, develop a working and differential diagnosis or diagnoses, and use diagnostic tests to confirm. And figure out what the goal of the treatment is. Are you curing the disease? Are we just relieving symptoms? Are we replacing a deficiency like insulin or treating hypothyroidism? Or is it just long-term prevention of a problem in the future like osteoporosis? It's not groundbreaking, but you always want to collaborate with the patient. You have to have a buy-in. There's a lot of evidence out there for a collaborative team is the way to go in treating a patient, involving all disciplines, involving the patient, can really help get buy-in and have the patient help the patient be compliant. You want to use evidence-based guidelines, individualize them for each patient. Realize that evidence-based guidelines are very, very helpful, but they're written to treat 95% of patients. A great example of just a quick example is proton pump inhibitors for GERD or heartburn. They're all equally effective, and we'll talk about this when we talk about GI medications. They're all equally effective. It doesn't mean that every patient gets effect from all of them. So you may have to try one. If it doesn't work as well as you think it should, switch and try another one. There's a little bit of switching even between a different class. Antidepressants are the same way. There's a lot of medications that they're not all exactly the same, but they're all equally effective at a population level, but maybe not so much for the individual patient. You want to consider the pharmacokinetics and pharmacodynamics of the drug, how it's going to interact with their other medications. Are there certain comorbidities that are going to prevent this drug from being metabolized or being cleared through the kidneys? Is it cost effective? If they can't afford it, they can't use it. Some medications just aren't cost effective for the benefit they get. So you kind of want to follow up and see what does the literature say the benefit is. There's a lot of drugs out there, for weight loss that you lose about 5 pounds, and for $200 a month, every month, it's not worth 5 pounds just for that. Or it may be, depends on the patient. So experienced providers use experience and pattern recognition. So there has to be some of that also. You'll hear the term anecdotal evidence. What you don't want to get into is the falling into the habit, I knew somebody who tried this medication, so I'm going to do it also. But you do want to rely on guideline recommendations plus your experience in identifying certain characteristics of a patient or certain disease states in order to be able to put those together and to treat a patient. Not just, so-and-so, they said they really like, this name brand medication, so I'll just use that. And again, these are all good slides, but we're not going to talk on each one of them. So when you start a treatment, important to talk about when writing a prescription, discuss whether the patient has the ability to pay for the prescription. These 3 things listed here under these bullets are great. They're also a gigantic pain. Insurance copays depend on the drug, whether it's generic, whether it's name brand, whether they've met their deductible, whether they're in the donut hole, if they're on Medicare, how many days supply their prescriptions for. So please don't ever tell a patient your medication costs this much on your insurance, or it's a $4 medication. Just like listed below, $4 retail list. Those change constantly and are nothing like, I think it's at least every quarter, and they're not nearly as robust as they used to be. Generics are often less expensive than name brands. Name brands a lot of times have coupon cards to get it at a discount. All of those coupon cards, number one, will not work with Medicare Part D, period. They just won't. And they also won't work with any other federal or state government sponsored insurance. Not if you work for the state, but like obviously you can't use them with Medicaid, Medicare, those kinds of plans. They also have a maximum benefit, most of them. They'll say in big numbers, pay no more than $5 for this prescription. But on the back in fine print it says, card will pay up to $100 per month. Then the rest is up to the patient. So be careful when you're looking at how affordable medication is. If you're not sure, call a local pharmacist and get their opinion, because most medications have a generic alternative that you could switch to that can be a lot more affordable for the patients. You want to educate your patient. Poor adherence contributes to a lot of problems. I believe the last time I saw the number that 60% of prescriptions don't get filled after the first month. And it drops a lot even more after 6 months. So you need to educate the patient what to actually expect of the medication, what are the actual benefits that are going to come. If they're not going to feel an effect, you need to tell them why. Most blood pressure medications are stopped because they don't feel bad when they don't take it. They might have some side effects when they do take it, so why would I take it? You need to educate your patients. Any information you provide should be at a 5th or 6th grade level. You want to make sure that anybody who gets it can comprehend it. You want to tell them the purpose of the medication, all instructions for administration, and any adverse drug reactions they can expect. Again, if you don't have time or you're not sure what to expect, contact the pharmacy. Any pharmacist would love to talk about this information, as opposed to most likely what they're doing, answering phone calls, dealing with insurance claims and things like that. So most of them will pharmacy nerd out to being able to talk about these things with their patients. Monitoring effectiveness, you have passive monitoring, so the patient knows what to expect, and active monitoring, which is checking labs at follow-up. You have a lot of drug factors that influence drug selection. You can go through, these are most of them self-explanatory. Your book goes more in detail on this. And these slides go more in depth. Pharmacodynamic factors, just going to touch real quickly on therapeutic index. A term you'll hear is a narrow therapeutic index medication. That means that it has a very small window in which it is therapeutic. So Coumadin, the blood thinner, INR window, they have AFib 2.0 to 3.0. Any higher, they're at risk for bleeding. Lithium, therapeutic window 0.6 to 1.4. Any higher than that, you're risking mental status change, coma, and death. Digoxin, the same way. There's a small list of medications that are a narrow therapeutic drug, which you require routine monitoring. You have to watch for side effects. If I were you, I would Google narrow therapeutic index, keep that list of medications with you. That way, if a patient comes in and you see, oh, this patient's on Coumadin, I need to do a drug interaction check anytime I change a medication for this patient, just to make sure. Therapeutic factors. What kind of evidence for therapeutic impact will there be? Clinical trials, guidelines, systemic reviews, randomized controlled trials. The two big things you'll see are the numbers needed to treat and the numbers needed to harm. Very simply, number needed to treat is how many patients do I have to treat to get the positive outcome or prevent the negative outcome in the trial. So if you're looking at a new blood pressure medication, you're seeing how many, can it prevent strokes and heart attacks? How many patients do I have to give this medication to prevent a stroke or a heart attack? The lower the number, the more effective that treatment is. Same thing with the number needed to harm. If it prevents strokes and heart attacks, but we see it causes acute renal failure, how many patients do I have to treat with this in order to cause a case of acute renal failure? So again, you want a low number needed to treat, which means it's very effective, and a high number needed to harm, which means I got to treat 50,000 people to have a case of acute renal failure. Cost of the patient. This is cost and side effects are probably the two biggest determining factors if a patient's going to take their medication. The effect, unless it is a disease state that will kill them soon, or it is incredibly uncomfortable, cost and side effects are going to influence that the most. Obviously, if you have somebody who has poison ivy right now, or they're in excruciating pain, and you give them a pain medication, they care a lot less about the cost and a lot more about getting rid of those symptoms. But outside of that, and especially a lot of our disease states that are slow building disease states, COPD, dyslipidemia, those kinds of disease states, cost and side effect profile are the biggest contributors to noncompliance. Formularies, you're going to see that word a lot in your practice, whether you're in an inpatient facility, and that's the list of medications you can use, usually in your facility. Usually there's extra formularies based on disciplines, so cardiology may be able to use these extra medications, oncology can use these chemo agents, or you're going to have insurance formularies, which dictate what medications a patient can use their insurance for. Now, insurances have to cover at least one medication in every category, but then they also have tiers. Tier 1, 2, and 3 differentiated by cost. So Tier 1, you're usually talking like a $5 generic, maybe $5. Tier 2, maybe $40, just to kind of give you made up numbers. And Tier 3 requires a prior authorization where you have to show, okay, I've used these other medications before, they haven't worked, we've done some kind of genetic testing, this medication is indicated, so that's why we need this more expensive one to get it approved, and then it may be $100 still each time for the insurance to cover it. So formularies, you're going to hear that a lot in your practice. Adverse drug reactions, this will be pretty quick. Adverse drug reaction is any undesirable or unintended effect occurring after administration of a medical product. So two types, pharmacological, which is most of them. Drugs have side effects. It's just people for some reason forget that. It may sound dramatic, and it probably is, but a lot of times I remind my students that a medication is essentially a poison you put in your body to prevent it from doing what it wants to do. Your body wants to have high blood pressure due to your size, your weight, your salt intake, cardiac output. Your body wants to not respond to insulin because it's downregulated its receptors so much because of elevated blood sugars for so long. That just happens. So you are having to put something in your body to prevent it from doing whatever it wants to do, which is usually compensating for something else that's going on, like downregulation of those insulin receptors. So type 1 allergic response is an anaphylactic reaction. You know this with the rash, the hives, the closing of the throat, scratchy throat, maybe fatal if not treated immediately. Type 2 is an autoimmune response, thrombocytopenia, drug-induced lupus, hemolytic anemia. A lot of medications that have this response have a warning about this. It's not usually a all of a sudden ibuprofen is causing this. Thrombocytopenia may be like Depakote. We know that it causes a dose-dependent reduction of platelets. So you may have a patient who develops thrombocytopenia. A couple other types you can read through. Types of ADRs, you'll have different levels of medication, time-related ones, dose-related ones, different severities. Your wherever you work will have some kind of rating system. Usually it's like a 1 to 9 rating system, with 9 being causing death in a patient. 1 being that it's a known side effect, should have been expected. So predicting adverse drug reactions, the extremes of age are where they're most common, in the young or the old, but neither one of them has sufficiently functioning liver and kidneys. They don't clear the medication as well as they should. They absorb it differently, so that's why they're at a bigger risk. Body mass can affect it. Gender, women tend to be smaller. You can have different fat distribution. Pregnancy changes. You'll see a lot of medications that if one woman becomes pregnant, like Synthroid, thyroid hormone, you might as well just go ahead and add 50% to the dose when she becomes pregnant, because you're having so many physiologic changes, a bigger area of distribution, that kind of stuff, that you just need to, that's what's going to take to keep her within normal limits. Time of administration, obviously it's very important for certain things like Synthroid and proton pump inhibitors to be given on an empty stomach, and osteoporosis medications. Some have to be given with food, like the antipsychotic Geodon requires 500 calories of food to be properly absorbed. Things during pregnancy, you have teratogens, which are known to cause birth defects and or miscarriages. You'll have some medications that still have this category labeling. Category X means absolutely contraindicated in patients. So ACE inhibitors, ARBs, Coumadin, those are category X. Methotrexate, I believe. There's lots of others that are absolute contraindications. You do not give it to a patient because of the risk to the infant. You'll have A, which is okay to give, B, which is trials have shown that it should be okay, C is kind of where most drugs sit, and then D is you have to evaluate the risk versus the benefit of a medication. Now you have most things are category C because we don't do trials on pregnant women. It's not ethical. So a lot of this is based off of case studies and what we've seen afterwards. And a great example of this is the current COVID vaccines that are out. Everybody asks, is it safe in pregnancy? Well, technically, we don't know, because we're not going to get a group of 10,000 pregnant women and give them the vaccine and see what happens. But we've seen through patients who got pregnant while they were in the trial, and pregnant women who have gotten the vaccine, that it does appear to be very safe for women who become pregnant. In 2015, they changed to where instead of just having a simple ABCDX, they are now having new labeling where they're going to tell more about it. So the risk of Lamictal, an anticonvulsant, causing cleft palate, they're going to tell you what the risk is. That way you can better decide if they should get the medication or not. So like with Lamictal, you may it has a chance of causing cleft palate, but let's say the woman is 20 weeks pregnant. Well, I believe the palate closes at 12 weeks. So you're not really at a risk. You can't unclose the palate. So, you're not at a risk for that birth defect anymore. So they're giving more information about pregnancy, lactation, and they're adding in the reproductive potential of these for medications also. So you're slowly going to see, I think we're still seeing information added to those as time goes on. Lots of adverse drug reactions are going to be caused by drug interactions. So be careful watching those. We'll talk more about drug interactions at your, what's it called? Not the in-service. But where y'all coming? Y'all are coming in March, and we'll talk about cytochrome P450 and different ways that there are drug interactions. But drug interactions are a big part of drug interactions are a big part of adverse drug reactions and failure of therapy. So always look for drug interactions when you're starting a new medication, and possibly when you're discontinuing one. Nutrition and nutraceuticals. We're gonna go through this fairly quickly. A lot of it you can just read. But nutraceuticals, we're talking about over-the-counter medications, natural remedies, fiber, vitamins, prebiotics, probiotics. Um, they do have drug interactions. They do affect drug absorption. Just because they're over the counter doesn't mean they're safe. It's actually a lot easier for a nutrient or a supplement to hit the shelf over the counter than it is for it to become a medication approved by the FDA. Over the counter vitamins, supplements, anything like that actually has to be proven unsafe before they can demand it being pulled from the market. So just because it's over the counter doesn't, a lot of people think it is, but doesn't mean that it's safe. A lot of those types of medications have drug interactions, and a great example is St. John's wort. There's a lot of drug interactions with that medication. Also, anything that begins with the letter G, garlic, ginkgo biloba, there are lots of potential for drug interactions also. And again, this will go more in depth. Your CYP3A4, which metabolizes a lot of enzymes or a lot of medications. You can see there what affects those levels. Cytochrome P450-1A2, which has a lot of medications. There's some that affect that one. Even things like smoking can affect the CYP1A2. And that can cause the metabolism to be induced, which means that the blood levels are going to drop and might not be effective for patients anymore. Again, these are more examples. I do want to talk about this metronidazole and alcohol. That's definitely a combination you want to warn people of. That'll give you like a disulfiram or antabuse type reaction. You can even have alcohol that's in cough syrups and hand sanitizers, cause that horrible nausea and vomiting. So you want them to wait at least several days after stopping it. So we're going to skip over these. A lot of these are just good examples, places to look, specific vitamins and minerals in general. Fiber, everybody knows that fiber, vitamins, you need a sufficient amount. I'm not personally a big believer in super therapeutic doses of vitamins, even vitamin C. Most of the evidence that's out there shows that vitamin C doesn't do a whole lot even for the common cold. But for the most part with these medications, if they're not getting it in their diet, or they may not be, have them take it over the counter in a multivitamin or specific bottles. It can become very expensive, but try to do a multivitamin if you can, and then if you basically need to assess, is it going to hurt them or not? Is extra vitamin C going to hurt them? Probably not. So let them go ahead and take it. Vitamin D and K it's really hard even on these fat soluble vitamins of A, D, E, and K to become toxic. I think vitamin D, you even have a 50,000 once a week. I think you have to take 50,000 units every day for something like 12 weeks for the potential to become toxic. So it's very, very hard to do. Folate, we know the importance of that during pregnancy, along with other medications, calcium for your bones, irons for anemia, fatty acids, keeps going, plant sterols, helping with cholesterol possibly. Obviously if people can eat foods that are high in these, seeds and nuts, as opposed to just taking it over the counter, that's the healthier way to do it. It's better absorbed. The most benefit from it can help with the diet that might be leading to the increase in cholesterol. Prebiotics and postbiotics, great for when around antibiotics. You just want to look for something that has Lactobacillus acidophilus or Bifidobacterium in there. So both are pretty good, especially for GI upset with antibiotics. Herbal therapies and cannabis. This goes through the history of of herbal medicine. Um, you can read through this, but depending on a person's culture, they may be a strong believer in herbal medicine. Several medications have been found in from these sources. Our statins were pretty much found in red yeast rice. That's essentially lovastatin. Um, so, I had one time a woman who came in and she said, "Yeah, I had horrible aches and pains on lovastatin, and they told me to get red yeast rice, and I'm still having them." And I said, "Well, it's because they're the same thing. That's where we found it, and then we made other ones in a company, in a lab." And she said, and she was so shocked by that she stopped taking it. They switched to something else, and her myalgia went away. So um, there is benefit to herbs, but when you have a patient who comes in and you do a med rec to see what they're on, always ask them if they take over the counter or herbal medications, because one, they don't think of them as medicines, and two, there's a lot of potential for drug interactions. So you want to look and see what they are. I've got a document under this module that goes through kind of a lot of the most common herbals you'll see in a pharmacy over the counter area, and what they're used for, and any that you need to watch for. So feel free to take that and add to it, do whatever you want with it in your practice, because you will see a lot of patients who are on that. Again, a lot of these you'll see, you'll be very familiar with these medications. You know, can be very beneficial, can also have drug interactions. That's just really the main point that I want to enforce, and that also always, if your patient brings up an herbal medication, most likely they've made the decision to take it. So you really want to look at, is it going to hurt the patient or not? You can make a recommendation for something else or make a recommendation to use it, but they've most likely made up their mind. They want to see if you're okay with it, and then and go from there. So those are the aspects you really want to focus on. There are some cannabinoid products that are on the market. So dronabinol is a synthetic cannabinoid for nausea and vomiting, a lot of times used for and appetite stimulation. So you'll see it for chemo patients, or we've got some patients who are a little closer to end of life and they're not eating well. Still pretty functional, but we've used it as an appetite stimulant, a lot like Megace in that aspect. You got Nabilone, nabiximols. I haven't seen that one before. I don't think it's approved in the United States at this point. And then cannabidiol, Epidiolex, which is approved for seizures. I know somebody who takes this. It's fairly effective. It's a lot more stable, and the dose is equivalent from batch to batch compared to over-the-counter CBD oil. They actually started with over-the-counter, and then the neurologist, once that seemed to be somewhat effective, they switched them to the Epidiolex that they had to get through a specialty pharmacy, but it keeps the dosing consistent. That got a lot of benefits. Obviously there's still, adverse drug reactions. Even cannabis has negative effects, but it does seem to have a lot of benefit that I think we're really going to discover in the next a lot more in the next 10 years. Real quickly, IT and pharmacotherapeutics. IT is growing everywhere. It's now mandatory that you have an electronic health record, computerized order entry, and clinical decision support systems. Like ours is based off of Micromedics, so it does our drug interactions and dosing count checks and that kind of stuff. It supplements what we're doing in the pharmacy. Most hospitals have electronic health records at this point. Outpatient facilities also. Most have done away with paper charts at this point. That way, the information is more accessible to everybody, and a lot easier to see between disciplines what's going on with the patient. So it's been great. Technology is great as long as it works. So this just goes through the different types of information. Medication reconciliation. If you're inpatient, you'll see this being done a lot more now when a patient's admitted. Getting an accurate list of what the patient's on, because most patients don't know what they're on exactly, or they're confused by the doses they should be taking, if there was a dose change recently. So a lot of inpatient facilities call the outpatient pharmacies to verify what dose they're on, and a lot of patients are going to lie to you and tell you, oh yeah, I'm taking all those, and then you call the pharmacy and you find out they haven't been filled in 3 months, which is why they're in for DKA as a diabetic, not because what they were on wasn't effective. So those are all the slides. We've gone through it fairly quickly. I'm going to try to do this with each section. Some are going to be a lot longer than other ones. I'm going to go ahead and apologize for the diabetes section because that one's very long. But there's a lot of really new information that's changed how we treat diabetes in the past 5 years that's come out. So we'll go from there. If you have any questions, give me an email. Shoot me an email or message in Canvas. Usually, if you send it through Canvas, I get a notification on my phone. My Anderson email I try to check 2 or 3 times a week. So do it through Canvas if you need something urgent.